Hello, my name is Tim Andrews. I'm in the ISU DAT cohort of 2020, and today I'll be talking about comparing the active release technique versus the positional release technique, or strain counter-strain. So there's a lot of similarities and differences between the two different techniques. Just in general, the positional release technique is a very passive technique. It really just involves, the main part is just shortening the affected tissue and holding that position. Whereas with the active release technique, you're applying pressure on a affected tissue, and the patient is going into a shortened, and then they're actively going into a lengthened position. So pretty big differences. And one of the interesting things with the active release technique, even though it's been around for quite a while, seems to be a lot of limited literature and discussions on the theory about how it works, which is interesting. But we'll get into that in a little bit. So basically, we'll talk about the differences first with the application. So first, why do we apply either of these techniques? Well, with the active release technique, you're palpating for muscular adhesions or trigger points or muscle strains. That's kind of the literature. Those are some of the things that they were looking for. So the similarities between these are you're palpating for muscular pain, but so positional release technique is very different. The theory is you're palpating for tender points, which is different from other conditions. And even though some literature, some articles, they treated positional release technique for things like trigger points, that's not what the theory is behind. And so what tender points are a less than 1 centimeter round tender area, and which can be found in muscles, tendons, ligaments, or even fascial tissue. So yeah, that's kind of the big indication differences. Now, contraindications. I could not find a lot of contraindications that are stated in the literature for active release technique. And the only one that was kind of different compared to active release technique for PRT was pain during the treatment position. So the whole point of PRT is to have the patient in a position without pain, and you're holding that for a certain period of time. So you don't want to have them be in a pain. You want them in a position of comfort, which we'll get into in a little bit. But basically, contraindications for PRT: open wounds, sutures, fractures, hematoma, infection, aneurysm, cancer, acute rheumatoid arthritis. These things I would believe would be very similar to active release techniques, along with many other different types of manual therapy. So I think kind of across the board, we can kind of say that you really shouldn't use this technique around these types of conditions and areas. So the big difference between these two techniques is on the pressure and the hold, along with the movements and positioning. So with the active release technique, you're applying pressure on the treatment area, applying compressive force and shear forces. So a lot of times it's not just pushing straight down, it's pushing down on the tissue and across the tissue. And you're doing that for about 5 to 20 seconds, and you repeat that 3 to 5 times. And both these techniques, you're both using your hands. So with PRT, the difference is you're palpating and finding those tender points, but then you're putting them into a position of comfort and shortening that muscle, and you're not applying that much pressure onto the tender point. The only thing you're doing is just palpating and talking to the patient to see if, with putting them in that shortened position, if the pain has been reduced. And just so you're finding a position where the pain doesn't exist. So yeah, that kind of leads us into talking about the movements and the positioning differences. So with ART, you're in a shortened position, which is kind of similar to positional release technique, but then the patient or sometimes the practitioner is moving into a lengthened position. So they're going from dorsiflexion to plantar flexion, etc., doing opposite movements. And another big difference was between the two techniques is with ART, you should not experience, or with ART, you may experience some pain and discomfort during the treatment, whereas with PRT, you won't have any pain, or shouldn't have any pain, otherwise the treatment's not being effective. So similarities are the shortened position, also, that tingling, numbness, tissue temperature changes may occur. Once again, this was not found in the literature, but from my own personal experience with ART, some of these things are found or could be found to be happening. One of the things with ART is we're working on releasing other tissues other than muscle that might be in adhesions, such as nerves and stuff. So maybe some numbness and tingling could be found with ART. So treatment goals. So similarities are that you're trying to decrease pain and increase range of motion. With ART, it's based around improved pain dysfunction all around muscular adhesions and restoring motion in those tissues. Also releasing these entrapped tissues, vascular structures, nerves, those types of things. That's kind of some theory behind it. Things that are kind of entrapped in the fascia. So that's kind of the theory behind it in the treatment goals. Whereas in PRT, improving pain dysfunction at tender points rather than at trigger points. And also you want to reduce pain to 70 to 100%. I find that interesting and different. That is kind of the outcome goal. And even when you're placing the patient in the position, that maybe their tender point might still have a little bit of pain, but you want a reduction of about at least 70%. So that is different. And basically you could continue to move them into a position of comfort, shortened position until you can find that pain reduced. So the theory is with ART, application of compressive forces releases adhesions from repetitive stress. You're applying shear forces as well as compressive forces. And I kind of think it's similar to like a trigger point release, that the pressure releases the actin and myosin, and kind of relates to that. I think one of the interesting things with ART is that movement component compared to a trigger point release, and really you're addressing the movement dysfunction. So if they're having a issue with extension flexion, you're specifically addressing that movement and trying to improve that movement through the application. So I think it's kind of interesting that they didn't really address how that active component compared to a trigger point. I had some trouble finding some comparisons, but I think it kind of relates a lot to other types of treatments, such as wow, blanking. Close to things like PNF stretching. It's working with the muscle spindles and the like Golgi tendon organs, as well as it's similar to the motor end plate theory, ATP, energy crisis, just all those things, all kind of similar and related. But I think it'd be interesting to kind of really understand the theory behind why active release technique works or does not work, and comparing it against trigger point releases and other types of manual therapy. So not a lot of similarities in the theory between the two of them. So the theory behind PRT is that basically because an injury occurs and it occurs to the muscle spindle, and the muscle spindle is in charge of sending to the brain the length of the tissue. That's kind of the whole job of it. So that muscle spindle has been damaged. It's no longer active or accurately sending a signal to the central nervous system saying the length of the tissue is blah, blah, blah. So by placing the patient in a shortened position allows that muscle spindle to kind of relax and calm down and reset and send the right signal about to the CNS. So yeah, that's kind of the big theory differences. Once again, with PRT, I think could also be related to the ATP energy crisis, having a muscle that's constantly contracted, allowing that by putting it in a shortened position, having that process kind of reset, and also events at the motor end plate, presynaptic, synaptic, those mechanisms may also be related, but basically not by putting it in a shortened position, allowing that position to kind of relax and reset and all those different junctions. But the theory behind it really addresses things about the muscle spindle. So clinical focus, this is kind of difficult to kind of find. Similar articles that compared, I couldn't find any articles that compared specifically ART versus PRT. But I did find an article, 2 different articles that looked at upper trapezius pain and neck pain in general, and kind of compared the two, or compared and against different things. So with ART, they found that improved or decreased pain, increased range of motion, and increased pain pressure threshold. And it did so compared to joint mobs. They did a better job of increasing the pain pressure threshold compared to joint mobs. And with PRT, that combined with exercises compared to no exercise, just exercises, PRT was helpful in decreasing pain, increasing range of motion, and increased pain pressure threshold for upper trapezius pain. So basically, what does this all mean? What does this all matter? ART and PRT may be effective in decreasing pain and increasing range of motion with patients. Really, the big difference between the two is that the theory behind it. PRT is about placing the patient in a position of comfort for 90 seconds to 3 minutes, whereas ART is you're placing a patient in a shortened position, then you're applying forces and then having them go through range of motion. So that's kind of the big differences between the two of them. Yeah, so that's, but both need more research. I was very surprised with what I found in the literature with active release technique, especially with, I feel like how active and used it is. I've heard about the technique a lot. So I was kind of surprised with the lack of literature on it in high quality studies. Positional release technique has been around a little bit longer, and it's regularly used by osteopathic clinicians, and it's an osteopathic technique. So there are more articles that use it. So yeah, but once again, I think it definitely needs some research, more research, and it'd be interesting to kind of actually compare the two techniques and see their effectiveness. With both of them, I would like to see the theory behind each technique also compared with the ATP energy crisis events at the motor end plate, more than just the muscle spindles or somewhere. Yeah, just want to see exactly how the technique works and why it's effective from a physiology standpoint, and not just it decreased the patient's pain. So yeah, thanks for listening.